Thanks for joining me. I know
Yeah.
you got a busy schedule today. How are you
No, I
doing?
don't. It's just a baby, man. I mean, it's amazing. The older they get, the more they suck you in, I'm finding myself having to do more and more things as she gets older. But,
Oh, God.
yeah, and,
You
Fridays being the only day off, everything just kind of crams into one day, it's just it's okay. It's part of the game. So,
yeah.
yeah, no worries. In fact, actually, my wife decided to take the baby out, so they're going to Target. So we're good. We're good.
You got the
Yeah.
one baby?
One baby, yeah, 2 years old, yeah.
Welcome back to the All In, All On X podcast, where we take you behind the scenes of full arch dentistry, innovation, and the people who are redefining what's possible. Here we go beyond the procedures and into the lives of people shaping full arch dentistry. This isn't just about implants or workflows. It's about the lives we build, the decisions we make under pressure, and the leaders who push this profession forward when no one's watching. Get your head straight, because we're about to go all in. The All In, All In X pod is brought to you by JB Dental Labs, the elite lab trusted by full arch surgeons, prosthodontists, and digital forward practices internationally. JB specializes in precision full arch restorations, zirconia, PMMA, photogrammetry workflows, and fast turnaround times that don't sacrifice quality. JB delivers a truly digital workflow powered by their proprietary online portal for easy case uploads, real-time tracking, and fast streamlined communication. If you're looking for a lab that understands immediate load, passive fit, and the demands of modern all-on-X dentistry, then JB Dental Lab is redefining what a full arch partner can be. Learn more at jbdentallab.com.
Yeah,
I,
she's
I
a
gotta
handful.
tell you, I've got a 24-year-old, a 19-year-old, and I've got a baby under one, and
I know. I saw
it
that.
gets way harder as you go. The 24-year-old has become the biggest worry,
Wow,
you
wow,
know.
interesting.
Well,
Wow.
because they're like, "Dad, how am I gonna buy a house? How am I gonna be doing
Oh,
this? How
yeah?
am I gonna do that?"
But
"God, dinner's expensive." I'm like, "Okay, we'll figure it out. We'll get you there."
yeah, I can
You know?
imagine. Yeah, for sure.
Back
Okay.
there was a time where it was, like, "Okay, gotta change a diaper. Okay, gotta go to the play date," "Okay, no big." You're like, "Oh my god, how am I gonna fit in that play date at 2 o'clock on a Saturday?" And now I'm like, "Oh, I gotta help my 24-year-old find his forever job."
Uh, at the same time, you have to be a surgeon, you have to be a husband, you have to be a leader, you have to be a prosthodontist, you have to be a friend. There's just so many other hats you have to wear. So no, I get it. I mean, but it is what it
Absolutely.
is. I mean, it is what it is.
You're
We
doing
have
great. Hey,
to
look, and with that, let's kick it off. Um, I feel like you need no introduction. I'm honored to have you here on the show. But for those that don't know, today's guest, Safa Tahmasebi. Is that
Yeah,
right?
you got it right.
Tahmasebi, a
There you go.
Florida. My Marine Corps days, I've been around the world. So
Yeah.
Safa Tahmasebi, a Florida-based prosthodontist, Tampa, right?
Actually, I live in Jacksonville, Florida.
Oh, Jacksonville. I got that wrong. So Jacksonville, Florida, you specialize in your prosthodontist, complex prosthodontic rehabilitation, specializing in full arch reconstruction. You are a true architect, an architect behind surgical execution. And I know you are heavily focused, obviously, like every prosthodontist should be, at occlusion, vertical dimensions, long-term biomechanics stability. You're an educator, and I'm excited to have you on this show because your photography and your work and your documentation of cases is spectacular, my friend. So
Thank
welcome. I'm glad to have you
thank
here.
thank you. Likewise, likewise. Thank you. It's an honor. I know both of us have busy lives and fitting everything together, and I know you probably have a lot going on. So thank you for taking time to do this. Thank you.
Yeah, no, great. I'm honored to have you. Let's get into, education. I've seen you Blue Sky. Were you a Blue Sky educator? Are you still Blue Sky educator?
No,
Pecos Institute? Where?
yeah, so I teach at the Picos Institute, and then I'm a KOL for a couple of different implant companies. So I just do my own stuff on the side. But yeah, that's pretty much most of what I do, my education. When I was in Dubai, I used to do some more international stuff, but now I do probably 2 or 3 international events a year, but majority of what I do is at the Picos Institute. And then outside of that, what I do are study clubs. Friends and colleagues would call me and say, "Hey, can you come and talk to my referral base?" Or, "Hey, can you come talk to my staff? Can you come talk to my other doctors?"
Yeah.
So those are the kind of education that I do outside of what I do at the institute.
So a lot more independent consulting, if you will, like going to offices and educating.
Yeah, yeah,
Yeah.
helping lift up the spirit, increase the quality of care, and improve the patient care, and also motivate teams to be better and do better and excel and do better for the patients.
Yeah, I mean, that's fantastic.
Yeah.
Everybody that knows you, they talk about your humble nature and your brilliant mind.
Oh,
Yeah.
thank you.
I think that that's, tremendous to be able to put those 2 characteristics, together. You're very y y you know, speak on, what is it like to be an internationally recognized leader in implant dentistry?
Well, I don't know about that. I'm not. There's far better people out there, but you just do your best to care for the patients, and the rest will follow, right? I mean, I always tell my other dentists that I work with or people that I mentor. People would often ask this question to me. They would ask me, how is it your cases are so great? And I say, I treat every case as if there will be a post on Instagram, right? When you start a case from the beginning and say, okay, I'm going to take my pre-op photos, pre-op X-rays. Are these postable material? Right? You ask
Mhm.
yourself, how can I take a good X-ray? How can I do a good surgery? How would my implants look in a surgery? When I'm done with this case, is this smile going to be a smile that I could put on Instagram? And when you
Mhm.
think that way, you start documenting your case that way, you strive for excellence on every case. It just becomes a habit. Everything you do has to look good on camera. Everything you do has to look good in a photo. Everything you do has to look great on an X-ray. And so when
Yeah,
you think that way, then the rest just happens by itself.
yeah,
Cases get documented. Everything just kind of falls into place. You begin to do the same surgery. You begin to do the same photos. You begin to make the same pictures. You begin to make the same before and afters, and then it just happens on itself. The magic continues to continue and be happen right in front of your eyes. So every case you do, think about it as an Instagram post, and then the rest will happen.
I'm gonna make my staff listen to the first 15 minutes of this conversation.
Yeah.
Uh, I literally we just had a big staff meeting at the institute, over in the classroom. I had all my staff over there, and I was in the clinical section of our after the administrative part of the meeting. I said, "Look, we are doing world-class dentistry, and I feel like nobody would know it because our photographs have to get better." I put up
Absolutely.
your page, I put up, Publio's page, I put up Knife's page. I said, "This is what we're going for," and I could go on and on with other people, Bark Bashara, Pay Ray,
Of course.
great photographers. I said, "We're doing world-class work, and the world doesn't know it, and we have
Right?
to do X, Y, Z," and so that's where we need to push our clinical work. I like what you said. Do take every picture, every X-ray as if it's gonna be published.
Absolutely.
Yeah,
Absolutely. Once you do it that way, then it just becomes a habit. And your staff also start understanding that there is this level of sort of excellence.
yeah.
And then they start doing the same, and everything falls into place.
Yeah, I mean, I took a random picture, off
Yeah.
the internet. I don't know if you remember this case,
Oh, yeah, I
but
do.
it's tremendous. Just a quick photograph. I imagine your team isn't taking 12 photographs to find the best one. They're probably well
No,
versed at
just
just
one, just one,
dial
just
in. Just one.
yeah, one, yeah,
All right, for
one
the team
photo.
that's gonna listen to this later, did you hear that? Just one.
Just one. I get so kind of frustrated when when we were in residency or when we were learning photography, you take 500 photos. And then
Yeah.
to find that one photo, it will take hours. So what it was making us do is we would take that memory SD card and put it away. And months would go by and we start losing our photos. I
Yes.
don't like doing that. I call it photography hygiene. which means that we need to make sure that we just take one photo and keep it simple. One
Right.
photo, delete the rest off the camera before you leave the room. And then it just gets less storage space. It gets easier to find that photo documented. And also, that photo that captured that smile, that moment. And then you use that photo to do your postings and to document the cases.
Amen. And then,
Yeah.
I'm with you. I mean, I'll have somebody taking pictures while I do surgery, and that night I'll go to look at them, and I'll be there for 45 minutes and I get nowhere. Just can't find the best
Mhm.
photo. There's saliva in this picture, air bubbles in that, blood in this.
Right.
It
Before you hit that trigger, make sure that that's the photo, right? I mean, we live in the digital era. Of course, you may take 2 or 3 photos, but anything after 3, I think it just becomes the same, right? So you
right.
really taking your time. And also another, you mentioned surgery. Another tip I would give is time. You and I probably practice at the same level, and perhaps we do advanced surgery. I've seen your work. I know you do a lot of advanced stuff too. And taking photos in the middle of surgery can become a problem because, time is of an essence. I know you probably have an anesthesiologist on staff.
Right.
They charge us by the minute. So it gets, and not only that, the longer and flap is open, the more these patients will swell up. The
Exactly.
quicker, because we have the conversion, the quicker we can get these patients out the door, the better experience they'll have. Staff can get to have lunch. So it's standing there and spending 30, 40 minutes trying to find that one picture, it could really
Yeah.
put a lot of stress on the day and everybody else. And also staff kind of get, annoyed a little bit too because they want to
Yep.
finish the case, and anesthesiologists, of course, and the anesthesia team needs to get out of there. So what I have found that works for me with photos is I try to, as I'm working, I'm waiting for that picture perfect moment, right?
Hmm.
You don't take one implant, take a photo. No, place all your implants. And then as you're placing the implants, that one implant on the right side has a story. It has a teaching moment. It has
Hmm.
one attribute that you could put up there and an experienced surgeon will pick it up. Let's say you perfect the cortical plate, or you really preserve the facial thickness, or it was a beautiful implant trajectory, you fix it with a good abutment, or it was a good pterygoid placement and there is a money shot there that is very effective. That zygomatic implant that preserved the lateral maxillary wall, and you were able to get fixation with very minimally invasive osteotomy in a channel 4 zygo 4 osteotomy type, right? So when
Hmm.
that moment, don't stop there. Finish the surgery right before you're about to suture. Pick up your camera, tick, 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 take 4 or 5 photos of what you wanted, and then close. Right? Don't
Right.
disturb the surgery multiple times. To sort of remember that one shot that you wanted to do before you are about to close and suture. Immediately take off your gloves. Assistants come in, hold the retractor. You go in 1, 2, 3, 4, 5 photos. Put the camera down and close. That has been something that I've learned that is very effective.
You just taught me something because I'm guilty of it. I'll be doing a surgery and I'm like, photo, photo, hey, now,
Yeah,
hurry up, get a photo. And I'm like, oh, that was cool. And then I'm
yeah,
like doing something. I'm like, stop, I need a photo. I need a photo.
yeah. That stresses the team and stresses
Yeah,
yourself too. It
right.
stresses everybody. Yeah, yeah.
I like that idea.
You
Get
look
to a
at
stopping point.
Taras, Yurov Taras from Russia. You look at his work. I mean, just beautiful photography.
Mhm. Yeah.
Photos are so effective that you learn so much. I mean, I learned zygomatic surgery from photos, to be honest with you. I mean,
Mhm.
I was watching people like Guy McLennan, Yurov Taras, Dr. Andrei from Russia. I see all these phenomenally beautifully done osteotomies, and I would stare at those photos for hours.
Yeah.
And those photos taught me how to do zygomatic fixation just from the photos. It's really
Right.
remarkable what you can learn from photos.
And I think it's a great little AI tool for this little human brain AI here to reteach yourself some things because photos don't lie. Constantly, you'll finish a case and you'll go, "Oh, it's beautiful. I wouldn't change a thing." Or you'll look at a smile. You're evaluating prosthetics. You go, "I wouldn't change a thing." And then I'll take a little video of the patient talking, or I'll go back and look at my photos, and I'll go, "Oh, what about that? What about that?
Yeah.
That
Mhm.
that could have been. I didn't see that,
Right.
right?"
Right.
And then
You
you
learn so much.
learn.
Absolutely. I agreed. I
Yeah.
agree. You look
Yeah.
back and you're like, "Oh my God." Or you have an open flap of 6 implants, patients come back, and then you take a healed tissue photo.
Mhm.
And then you see that area that had less bone on the facial thickness, you have less attached gingiva. And then
Right.
it shows you that facial thickness
Yeah.
is a critical thing.
Yeah.
Or you see that zygomatic implant slightly off the maxillary ridge, but on the left side, it's buried into the maxillary ridge. But where it's buried, you have more soft tissue. What's happening there? And
Mhm.
so, absolutely, couldn't agree with you more. Photography is the best teacher of all.
Yeah.
Absolutely. No doubt
And
about
that's
that.
where, my, prosthodontic colleagues, perio colleagues, you guys are phenomenal at taking pictures. And, I think, I kind of 20 years ago, I might laugh and scoff at it. And I know it's the one thing that I'm missing as a GP in all my training. I've done the surgery, I've done the pros. I've got to do the documentation. That's where I have to go with my practice.
Yeah,
Yeah.
it's tough. It's a lot of work, though. I mean, not only just taking the photos, saving the photos, putting them to a drive, bringing them in,
Right.
editing them, cropping them, put them inside, putting
Yeah.
before and after. It's a lot of work. I gotta
Yeah.
tell you, it takes me a lot of times. Airports, airplanes, baby goes to
Yeah.
sleep, a few
Yeah.
minutes here and there, boom, you just jump on your computer, put them all together, and it's a lot of work. And also, I add to that is, you like you said earlier, you do all this beautiful work, you're in surgery, patient comes in, gets their permanent teeth, and they leave, and you never got to see the final product.
Right.
And that's tough. And so I'm very grateful that I have a partner prosthodontist with me. She was in the beginning shy of taking photos and doing them, but once she got on board, now she catches them. I'll be in surgery, she catches them. She says, "No, no, no, you're not leaving until I get that photo." And so
Yeah.
getting that um, sort of momentum in the clinic so that everybody's on board into making sure that this beautiful work is displayed takes a lot of work, lot of time. So I understand it's tough. It's tough, but you got to get the team to buy in. You got to get the team to be part of it. And I
Yeah.
always tell my team, I say, this photo is not just for me. This photo represents the lab technician. It
Mhm.
represents the anesthesiologist. It
Yeah.
represents the surgical assistant. It
Yeah.
represents the process assistant. It represents the person who actually sold the case.
Yeah.
It represents everybody. Everybody is behind that photo.
Music to my ears. In my
Yeah.
staff meeting I just had in the clinical segment, I said, "Wouldn't it you guys go through all this work, you produce all this beautiful dentistry, and if it doesn't happen on social media, if it doesn't happen in photographs, it almost didn't happen. You've got
Right.
nowhere to show it." I said, you put out this great marketing stuff. Now the lab technicians, I'm talking to them, you did all that work at the desktop. Wouldn't it be great to go to your family and friends and say, "Oh, what do I do? What do I look right here. Look at what I do. This is what I do." And for the salespeople up front to go, "Oh, hey, go to
Oh
our
yeah.
page. Take a
Oh
look.
yeah. Oh
Makes your
yeah.
job
See all the
so much
people.
easier."
Agreed. Agreed. And I got to tell you, Adam, a lot of these patients, they want to be photographed. They want it. They're
Mhm.
like, I paid all this money. I want to wear. A lot of them that I miss would come up to me and say, "Hey, how come you never took a post-op photo of me?" They would say stuff like that,
Yeah.
and I'm like, get your butt in that chair. Let's take your photo. Let's do it. So they want to be a part of it, and they like it. They like it.
When I first started taking a high, marketing profile on social media, I thought, "Oh my god, all these people are gonna be upset to be the other picture taken." Quite the contrary. They come in the consult room and they go, "I seen your Instagram page, I've seen your TikToks. I wanna be on there. I wanna be
Right.
next."
Right.
And
They
if
want
they
to be
see
part of the story.
oh, yeah, they see a whole bunch of people on the wall, pictures, and we do a lot of post-ops on the wall. I don't generally put the pre-ops on the wall. I just do a lot, but people go, "Hey, why is my picture not up there? Is there room
Hmm.
for my picture?" And we
Agreed.
we hear it all the time. You're absolutely right.
Yeah, yeah, agreed, agreed. Absolutely.
I'm I'm gonna make myself legit here. Um, this is I just hired a prosthodontist buddy. We're gonna make ourselves legit. This is my buddy James, and
Oh,
he does great work, and he's a good team member, and people love him. But I'm gonna up my photography game right here with James.
yeah, absolutely. You
Yeah.
should.
So
You should.
you guys watch out. Not that you have anything to worry about.
Yeah.
You're
Absolutely.
doing just fine. New dad. How is that? And you how long you been married?
Almost 7 to 8 years now.
Okay,
Yeah.
so you and your wife, you got time under your belt to know each other and your new dad, and how has that affected your practice and your profession?
Yeah, I mean, of course, I remember, I'm part of a few WhatsApp groups. Some of them are internal within our network or people, doctors that I know. So I used to post stuff every day. I'd come home after surgery and post, hey, this is the surgery I did today, X-rays. And I remember I went to a meeting and one of the girls, one of the colleagues, prosthodontist, she said to me, she says, Safa, when your wife got pregnant and you had a baby, we thought you were going to stop posting stuff, and so we were very excited not to see your postings anymore. but, but she said that looks like that didn't really do it. You're still doing it. You're still at it. So, I mean, luckily I have a wife that understands that I have a passion for what I do, and so um, I try my best to divide my time. Like yourself, being a father of three, I understand we talked about this, you and I, earlier. It's tough, but you have to do your best to make sure that you're there for your family. But at
Yeah,
the same time, you have to make sure you're there for your staff and your patients and your team.
yeah,
So it's a struggle, but you have to try to divide yourself between all of these lovely people in your life, and it's not easy. And you try your best,
yeah.
and it's work every day. So.
This segment is brought to you by JB Dental Lab, your go-to partner for full arch prosthetics, zirconia, PMMA, and digital workflow. With a proprietary portal, in-house designers, and an advanced education center, you will experience reliability, precision, and consistency. Visit jbdentallab.com.
Yeah. It gets harder, and then it gets easier, and then it gets harder again, I think. You
Yeah.
know, I don't know where you're gonna be, but I mean, I found myself coaching between the ages of 6 and almost 16, and, that was harder than my full-time job, so and I would never turn that in for the world. That was a great
I
opportunity to spend with my
agreed.
kids, but,
Agreed.
it's like having a second full-time job as they get to those ages, 6 to 12 especially. Then they hit the
Agreed.
teenage years, and they're kind of a little more gone, a little more absent sometimes unless you reel them in. Then they come back to you again when they're 18. That's the coolest thing.
That is. Yeah,
Yeah.
looking forward to that for sure.
Y yeah, absolutely. So are you, what are you looking for? Where are you gonna be teaching this year? Where can people find you?
So, there's a couple of events that are coming up. It's going to be a very good year. I'm giving one lecture in Athens in June from the 2nd to the 4th at the Zygomatic
Yeah,
seminar in Athens. And then soon after that, we'll go to the island of Mykonos to see some of my colleagues lecture. I'm also giving a live surgery course in Brazil with Dr. Picos at the Elapeo Neodent facility. So we're very excited about that. I'm also going to be teaching at the Picos Institute, teaching remote fixation without the use of zygomatics. That's the first time that we will be teaching this course over there.
mhm,
And then study clubs and
yeah,
small stuff here and there. I'm giving another lecture which is coming up very soon that I'm very excited, and I really hope that Adam, you would be there, and I think you should. And it is the first full arch complications symposium in May. This is a good one because I was thinking about this. People put on complications of zygomatics
right,
seminars. Well, that's a very small sort of niche thing that people like you and I do. Not too many people do zygomatics, and so
right,
to do a symposium on zygomatics is a great thing because you learn a lot from those complications. But we don't have a normal full arch complication symposium. I
right,
think we should, because as you already know, full arch is becoming very prominent. It's becoming
mhm,
very sort of, it's occurring all the time. A lot of people are doing more and more full arches. We needed a seminar on full arch complications symposium. And so that's coming up in May,
yeah,
and it's going to happen in Orlando. And I think it's going to be a good one. People are going to share their complications.
yeah,
And we need to talk about complications because
yes,
complications can happen to all of us. It happens to everybody. And so I
right,
think we need to have a symposium on full arch complications, and not only just prosthetics complications or surgical complications. What about anesthesia complications?
right.
We need to talk about that. Medical legal complications, soft tissue,
Psychological complications.
psychological complications. Agreed. Yeah. So we need
Mhm.
to talk stuff like
Yeah.
that. Absolutely.
You must be, sharing on the same wavelength in the universe with me because, our institute has, it started out digital pros, and then you find out you need a basic class, and you find out you need a remote class, and, oh, by the way, you find out really quick, I need a business class because everyone wants to interrupt clinical lecture for business questions, and then you need an FP1 class, and I thought, "What am I missing?" Complications. We need a complications weekend. And
Absolutely.
so I'm in the process of putting that won't be too hard. You can probably go
No,
to all of my cases and find a complication somewhere,
we
you know?
all have them. We all have.
Uh, I'll just open up, close my eyes and open up my patient charts. I'll find one. But I think we learn more from that. I've made it a point to try to stop posting just perfect cases. Not saying I have a billion of them, but
Sure.
because my time is very limited and I think we learn more from complications, I've got the baby, I've got the older ones that want to play golf and go shooting and stuff and just spend
Agreed.
time together. And I only have so much time. So usually when I'm posting, it's like, oh, hey, look at this interesting thing,
Mm.
and I feel like it gets a lot more response.
Yeah, you do. I've seen your stuff. You post some very interesting questions.
Yeah.
Great.
Keeping people, the danger of that is they'll think I'm not as good as you. Your stuff is always phenomenal, even right down to your signature.
Adam, I gotta tell you, a good friend of mine, Salvin from South Africa, said something to me that I probably wouldn't have understood in the beginning of my career, but now I get it. And he said that everything we do in dentistry, particularly in implant reconstruction, will fail. All of our works are going to fail.
Right.
It's a matter of time.
Right.
And the only difference between a good clinician and a sort of a suboptimal clinician is how long it takes for that failure to happen, particularly
Right.
for our younger patients. So
Right.
if we pay attention to detail and we do good work, good surgery, good pros, good to really take our time and plan cases correctly and treatment plan them correctly, that failure is going to happen a lot later. And if we have patients in their 60s and their 70s and the 80s, that's okay. But if we have patients that are 30 years old, 40 years old, if we don't pay attention to detail, if we don't foresee
Mhm.
complications happening, then that failure is going to happen a lot sooner in their lives. And so
Right.
everything we do fails. The only difference is how long it's going to take for that failure to happen.
Yeah.
And the better we do, the longer it takes for the complication to occur. But everybody has complications. And if you don't have complications, you're not doing enough cases.
Yeah.
Absolutely.
Oh, yeah. Yeah, like, I've heard it be said, if you haven't had a traffic accident or gotten a speeding ticket yet, it's because you haven't driven long enough or don't drive enough.
Correct.
It's probably a matter of time. Knock on wood for today. But
Yeah.
I couldn't agree more about that. I get asked all the time in our consultation room, how long will this last? And I say, nothing on this earth lasts forever. Everything is made to fall apart from your house to your car to your teeth. It's just a matter of how long it's going to last and who does it. And the other thing, so we have that conversation like you just said, and I could go on and on. But I'm seeing 5 years ago, I think everybody I saw was 50 and up, 55, 60 and up, just about. I am seeing so many people in their 30s. I don't know about you, but the need to do that FP1, early FP1, just yesterday in my consultation room, I had 3 consults back to back that were all 35 years old. If you can place implants but can't scale your practice, this course is for you. Core Business breaks down how to build a 5, 10, 20 arch per month practice, generating millions of dollars of revenue, learning systems, teams, marketing, and leadership. Stop guessing, start scaling. Core Business, how to 5, 10, 20. One time only, April 24 and 25, 2026.
Hmm. Hmm.
And just gross decay, hopeless teeth, but good bone. And so being able to build something that hopefully gets them another 20 years before you go to the remote anchorage, or just planning for the future
Sure.
if that's gonna be in the cards, because you never know what's gonna happen,
Correct.
and I think these offices that set things up with they're your permanent teeth, I think they're setting themselves up for failure with that
Agreed. Agreed.
psychological, profile.
Agreed. Agreed. I've just to kind of challenge you a little bit on
Yeah.
this FP1 world. I've seen, I've been in this full arch business for almost 16 years. And
Mhm.
the beginning part of my career was FP1, FP2s, because I was in that mindset that I say, oh, less is more, less is more, less is more. But then after I did those cases in Dubai for about 5 to 6 years, then I started seeing some of those cases come back just in
Okay,
5 years. Some of them would come back in 4 years. And I realized that, this FP1, FP2 world, we have to be very careful. I've
I
seen some
agree.
podcasts. I know people that have come on your podcast endorsing this technique. I think we have to be careful, particularly for younger clinicians who are getting into the full arch business. You have to make a very quick, perhaps maybe a logical decision at an early point in your career, whether you should be an FP1 surgeon or an FP3 surgeon. I think you have to make that decision at some point. And then, of course, when you and I can sometimes do one or both. But what I have noticed, and this is not just what I have noticed, clinically, there's some studies that have been published. The most famous study was published in 2003. They followed up patients for 25 years, and they looked at the resorption process of both the maxilla and the mandible and the direction of the resorption.
Okay,
Um, Patients resorb. When you extract teeth, you remove the periodontal ligament. The
right,
periodontal ligament has receptors in it that
right,
stimulates the bundle bone and tells the bundle bone, you stay here. When you
right.
extract that periodontal ligament and don't raise a flap or don't remove any bone and place the implants in that socket, the genetic predisposition of the body, that clockwork of resorption is on. And
Hmm.
so the implant stay in one place, but the patient's maxilla is resorbing and is resorbing in this direction. And so while I admire some of that beautiful FP1, FP2 work that's out there, I don't really believe that a true FP1 is out there in nature. In fact, actually, when you look at Carl Misch's book in chapter 5 and you go to his diagrams, he doesn't have a single diagram of an FP1 because he calls an FP1 natural teeth single implants. When the minute you lose bone, you lose interproximal bone. When you
Hmm.
lose interproximal bone, you lose papilla. When you lose papilla, FP1 is no longer there. And so while I like what I'm seeing in certain cases, particularly in Europe, people do a lot of grafting, connective tissue. My question is that a real FP1 or is it soft tissue, attached gingiva, or is it a pseudo FP1? Are we really supported? Those papillas, are they really supported by bone or not? And so how's it going to look in 5 years? How's it going to look in 10 years? How's it going to
Sure.
look? So I've heard this fourth arch that you should do an FP1 for those younger
Yeah.
patients and wait. But I also challenge those people that say that and say, hey, what if we remove 3, 4, 5 millimeters according to the patient's diagnostic smiles and lip
Yeah.
support, and we remove that bundle bone that's programmed to resorb. And in other words, we are doing that resorptive process for the patient. The patients are going to resorb in spite of us and not despite of us.
Hmm.
And so we sort of do nature's work in a way. And we
Yeah.
reduce 4 or 5 millimeters of that alveolar bone that's going to go away anyways. We place our implants a little bit palatally and then we graft and we do an FP3, but not a massive FP3. I call it FP 2.5.
Yeah.
And we do a nice patient work for these patients, and we don't necessarily have to say it's going to fail. It's just going to take a
Right.
long time. So I
Right.
challenge people that say FP1 sometimes because I don't think that FP1 is there in nature. So I always challenge people to think
And
differently.
I get all your sentiments. Your logic is sound. It's very reasonable. I think throwing out a blanket term of an FP1 as if it's an FP3 is the mistake.
Agreed.
Obviously, it has to be done with precision. But it's very technique sensitive. We throw in root banking, we throw in socket shielding, we throw in
Correct.
the appropriate osteoconductive, slow resorbing graft materials. We throw
Correct.
in exactly where the platform should be, how high the MUA should be with a biologic width so that you don't cause resorption, you don't cause
Correct.
periodontal disease around your implants. You throw in, the ponic design. There's so many things that go into, FP3. It's not easy, but compared to FP1, it's easy. We're going to level the bone, we're going to make it flat, we're going to hide the
Correct.
transition line, and
Correct.
there's a lot more room for error, for lack of a better
Sure.
word, or
Correct.
a lot of
Correct.
room for beginners. And you talk
Sure.
about doing FP1, you got you got a 12-step checklist and everything has to be perfect,
Correct.
right?
Correct.
So
Correct.
I'm with you and I'm with the other camp too. I mean,
I get it. I get it. Yes. But,
yeah,
like, to kind of again challenge you on, for example, root banking. Not an easy thing to do. It can
yeah,
get infected. It could have a problem. Or socket shield. To do 12 socket shields on a case to maintain that facial plate and interproximal
yeah.
bones. And I mean, that's not easy doing socket
No,
shields. You that's
no,
that's a
no.
12-hour operations, right? So I get it. I mean, again, also, like, I see some cases where you know, teeth were removed and they were socket shielded on every socket. But then, did those teeth really need to be removed? Why can't we just do crown and bridge and do nice ceramics and zirconia and preserve some of the teeth? So, and that's another thing I think you and I should talk about, and that is, when do you really need to do a full arch? Because we see a lot of cases, and
Yeah.
I'm in the work of publishing a paper with a couple of very good clinicians where we can look at the behavior of the maxillary sinus around zone 2 premolars. And when do you say, no, this case should not be done with full arch? Because the minute you extract those teeth, you have no way to anchor. And like you said, we have to go for remote anchorage. And so I think there needs to be a lot of education where not every case is full arch.
Oh, for sure.
And very few cases qualify for an FP1. And so we just have to be ready to be honest and practice educational honesty, and not put an FP1 course and say, hey, come give me $30,000, $40,000. I'll teach you to do an FP1, FP2, and not discuss the indications, when
Yeah.
to do it and when not to do it. I think educational honesty is very important in our era today.
Oh, for sure. Yeah. Just really having a real conversation about the longevity of what we're doing and the complications that can arise. Absolutely, I agree. And I think that this is more of a problem with business and marketing that everybody, you were, I think, a clear choice doctor before, right? Everybody
Mhm.
wants to open up a full arch treatment center and they want to just do full arch. That's something that's very hard to do, and it's something that's very niche. And one thing I'll say for me, and I'm wearing a full implant choice scrub top right now, because our practice focuses on full arch and dental implants and complex prosthodontics. But you know, in my consultation room, I exclude many people that they come through and they say, I think I need to have all my teeth taken out. And it's like, not so fast, my friend, you know, not so fast. I mean, I don't see it. I don't see it here. I think you need to go to this cosmetic dentist across town. I don't have
Mhm.
the capacity or the time to prep, 28 veneers and crowns. But
Agree.
there you have to be able to offer something else. There's also a lot of cases that you just can't put fixed into their mouth, with their maxillomandibular relationships and their atrophy. Maybe it's got to be removable, and you just can't take everybody and throw them into a fixed FP3 world.
Absolutely, absolutely. Couldn't agree with you more. And particularly with those cases where you look at an X-ray, you see the sinus is scalloping around the tip of the canine.
Yeah,
My friend, you're not going to get an AP spread. Pterygoids are not to be
yeah,
found. There is no backup plan for that case.
yeah,
The sinus has pneumatized into the zygomatic buttress.
right,
Zygoma is gone, pterygoid is gone. What are you gonna do? Right?
right,
And
yeah,
so, sometimes we have to really make sure that
yeah,
we have physicians and orthopedic surgeons, vascular surgeons, in particular vascular surgeons, when they do leg flaps and they do flaps in the leg and they do grafts and they take a vein from here and they attach it here and they do a lot of bypass surgery. They're constantly thinking about their backup plan. What if I take this vein and bypass it here? What if this graft fails? Where am I going to take my next vein from? We should be doing the same. If you have a
right,
case where the sinus is scalloping around the head of the molar, the premolars, and it's pneumatizing all the way to the canine, that means you're not going to be able to get zone 2 anchorage. And so you immediately
mhm,
look for a pterygoid. Pterygoid is not there. You immediately look at a coronal section to look for the zygomatic buttress. If the zygomatic buttress is not there, that
yeah,
case doesn't have a backup plan. And you don't touch that case. You try to preserve the teeth. You
yeah,
try to find alternative to be
yeah.
able to treat those cases.
Yeah, because if you get down that road and you've only got 2 or 3 implants in the anterior maxilla and you can't get pterygoids and zygos,
What do you
you're left with bar retained overdenture at best,
if
which
you're lucky?
is a whole nother topic for conversation
Right.
with lip line, transition line, maxillomandibular
Oh,
relations. Is it even indicated? That's a whole nother problem.
agreed. Yeah, you can
Yeah.
shoot yourself in the foot. Always have a backup plan.
Yeah.
Always have everything we should do. We do in full arch surgery. You must have a backup plan. You
Yeah.
must have a backup plan. Agreed.
Yeah.
You know,
Pterygoids.
I've reached a point where, sorry to interrupt you. I've reached a point where, if they bring me a consult and I'm looking at the X-ray, first thing I do, I go look at the zygomatic buttress. First
Yeah.
thing I do now. I don't look
Yeah.
to see whether it's bone in the alveolus.
Yeah.
I go to the zygoma. I see zygoma. I go, whew, okay,
Yeah.
we're gonna be okay here, all right? Or
'Cause
at
I've
the
got a bailout.
right,
I do the same thing. I pull it up and I'm like, as I'm talking to the patient and we're talking about their
right,
dogs and
right.
their cats and their grandkids, I'm like looking over at the zygoma and I'm like, "Okay, I've got a backup. I've
Right,
got a fail
right,
safe."
right. So you think the same. Yeah. I mean, it's funny because sometimes, my sort of sales consultants will say, Doc, this is why are you looking at the zygoma? I'm like, I'm sorry. I was just, because in my mind, I'm thinking backup plan, right? Immediately
Yeah,
looking for the pterygoid, looking for what happens if this case fails? What happens if this patient overloads your primary fixation? And what if you do have a problem? Are you
right.
going to have something to fall back on? So I think we need to think always backup plan. Agreed
Yeah.
with you 100%.
I gotta bring up, pterygoids that are hard to find. And
Yes.
it's interesting, and I wanna go back to a comment you made about a remote anchorage course without zygomatics, okay?
Yes.
But a quick thing on the pterygoid implant, I I love the pterygoid implant. I also know that it's very technique sensitive and you need to be highly skilled to do it. I think it's a
Agreed.
little dangerous teaching it to everybody, but everybody needs to learn.
Agreed.
But when I was doing these blindly until about, 6 months ago, there would be that occasional one you miss, right? That you
Agreed.
can't get, right?
Agreed.
I don't care who you are. If
You will
you
miss
hit
it.
90% of them, you hit 95% of them. If you say more, I think you might be lying to yourself.
Agreed.
But, I started going to I was tempted with dynamic guided navigation with XNav. They said, "Here, use this." And I'm like, "Man, not only am I getting 99% of them in, but with high torque." So
Wow. Good.
it just makes a good surgeon that much better
Wow.
and
That's great. Great.
yeah,
Yeah.
yeah.
Absolutely. Any
So
tool, because those pterygoids, like you said, it's a blind procedure.
yeah,
I don't care how experienced you are, sometimes
yeah,
you're not gonna get it. So agreed,
yeah,
if any tool is out there, that can help you, get a
yeah,
better, fixation, absolutely.
t
Particularly in those cases where, getting a pterygoid is absolutely paramount to being
yeah,
to able to avoid a quad, right? Let's say for instance, you have a case where the pterygoids are there and, the patient has a massive oral anterior communication, which is
right,
going to move your zygoma more anteriorly towards the first premolar.
right,
Getting that pterygoid is absolutely essential. And so, for those cases, if you can get a tool like navigation that can help you get those 100%, why
yeah,
not?
yeah.
Absolutely. It's best for the patient.
I mean, and they were asking me to try this, try this, try that. I was like, "I don't need it, I don't need it, I don't need it." But then when I was teaching and I saw these students getting into trouble trying to place pterygoids, missing them. They're like, "Oh, I tried to drill into this pterygoid 6 times," or "It's sticking into the nasopharynx," or something like that, and they're like, "What do you think?" And I'm like, "Okay, I need to be a more responsible educator. I wanna find a tool that helps the beginner do better work." And
Agreed.
then I found it also helps the expert get that much better. And on a side note, the prosthetic, I this isn't an XNAV commercial, but, they pushed it at me as a tool to make your implant stick better, and I'm like, "I don't have a problem with that." What it really does is just like any guided surgery, it makes your prosthetics leaner, smaller,
Agreed.
stronger. Yeah,
Agreed. Because the maxillary sinus is also in the posterior. And so if you could know the exact position of the sinus, you could really start your pterygoid osteotomy as anteriorly as the sinus allows you to do.
agreed, agreed.
Or more mesial the pterygoid, the better prosthetics you can fabricate.
Yeah,
Agreed. And
yeah.
yeah, based on this conversation, I'm going to look into the XNAV for sure. But because I
I
really
would.
agree, I agree with what you said because even the most experienced sort of surgeons will miss pterygoids. I miss
Mhm.
pterygoids every now and then,
Yeah,
and when you miss them, of course, you rely on zygomatics. But why not try to avoid that if you
yeah,
can, and
yeah.
cut down on the surgery time and make it simpler?
So, which brings me to the Zygo because I will guess 97% of my implant complications happen with Zygos. And not that it happens all the time, but if there's a problem post-op, 3 months, 3 years down the road, it's probably a Zygo. rather than a traditional. And being able to hit that pterygoid with higher torque,
Right.
I'm doing far less zygos these days. I'm going palatal approach, even shorter implants, because I got a strong in the back and a strong in the front. So do I really need to go zygo in the middle?
Right.
Um, and why are you teaching a remote anchors course without zygos? I just wonder if it's because of the complications or because
Absolutely. There's no doubt about that. I'd be lying if I say Zygomatics don't have complications. They absolutely do. However, those complications have reduced significantly. We can talk a little bit about how to do Zygomas correctly, so we
yes,
can talk about that, because I don't want to sound arrogant, and please don't think I am, but I don't see Zygomatic complications as much, and that is because we really have nailed it down to a very strict protocol that we follow. But we can talk about that
yeah,
separately. But yes, I agree with you. I think pterygoids is a game changer. And
mhm,
there was this sort of zygomania, you may want to call it, about 5, 6, 7, 8 years ago, where everybody wanted to do zygomas.
yes,
And I think that has calmed down a little bit. And I think the reason is because of what you just mentioned. You're spot on. I think it was pterygoids. Pterygoids um, uh, gave us posterior fixation. And because it gave us a posterior fixation, it was a game changer. And so we
right,
no longer need zygomatics, like you said, with palatal approach and with using good implant systems that allow you to angle more than 30 and still be able to use a multi-unit abutment to kick back that sort of trajectory back into the prosthetics. I agree that that has significantly reduced. So yes, I
mhm,
think Pterygoid is definitely a game changer, no
yeah.
doubt.
And I think you alluded to my belief that when you're having, and I have very few complications, but I was saying if I have an implant complication, it's probably revolving around a zygo rather than a regular implant typically, if it's not patient induced.
Yeah,
But many of these zygo complications, I believe, are almost iatrogenic, if you will. I mean, just based on how your technique, how you approached it, where you left it,
I agree.
where's the platform, how did you handle the soft tissue? Would you agree?
Sure. So I think what happened with zygomatics is that it's a dogma with the zygomatics. We have to be very careful when we talk about zygomatic implants, because there has been a very nice evolution of trajectory of
Yes.
history that
Yes.
happened. The Brennemark original zygomatic technique was to go through the palate, through the sinus, into the zygomatic buttress. Apart from
Right.
hygienic and speech problems, as these zygomatics implants flex, and at that time we were not doing any pterygoid, so there was a little bit of flexure on those zygomatics.
Right.
That flexure caused that entrance of the implants into that thin palatal bone to atrophy, and now you had an oral anterior communication, you had a fistula, and
Right.
all the stuff from the mouth was traveling inside the sinus. And because you were blind and you were running your jewels inside the sinus, there was all orbital injuries. And so what people like Carlos Aparicio and many other people did is that they took that experience from the late 1980s and the 1990s, and they realized that there were two complications with zygomatic implant fixation. Complication number one, sinusitis, oral sinus communications, and oral sinusitis. Complication number two was soft tissue dehiscence and soft tissue retraction, or soft tissue fenestration.
Right.
And what they did in 2008 is that let's fix the sinus problem. And they came out of the sinus, and the extramaxillary sinus approach started. It pretty much eradicated the sinus problem because we were no longer in the sinus. And in
Right.
fact, actually, fixtures were positioned and parked outside of the maxilla to the point that the body didn't even realize they were there.
Right.
But it fixed one problem, it created another problem, because now we have soft tissue dehiscence
Right.
because it was sitting outside of the maxilla. And now all of a sudden we have this massive retraction of soft tissue outside of the head, the body of the zygoma. Then we said, okay, now that we've fixed the sinus problem, let's fix the soft tissue problem. And that's when the Zaga protocol came into being. And the Zaga stands for Zygomatic Anatomy Guided Approach, which means that the zygomatic trajectory follows the patient's anatomy. And I've seen you talk about this many times. I really commend you for pushing people and improving education, because I've seen you talk about models and how models are so effective because they teach you that sinus maxillary
Right.
walls concavity. And because you know that sinus anatomy, what you do is you take a site-specific implant, such as a flat Straumann, for instance,
Right.
and you park that implant to what that patient's anatomy has. You don't get it into the sinus and you don't get it out of the maxilla. You basically park that
Mhm.
implant in a minimally invasive channel osteotomy in a Zygophore technique,
Yeah.
and you park that in there in such a way that that implant, the way it's positioned inside of the maxillary wall, the body doesn't even know
Yeah.
that that implant is there. If you look into my Instagram, there's some photos on there. You can't even the body doesn't even realize that there's a zygomatic implant there. So what that creates is that it creates this illusion that you get fixation outside of the maxilla and you get teeth to be fixated, but the body doesn't see that as an intrusion, and it doesn't become a problem.
Yeah. I pulled this off your Instagram page because I just reached behind me, I've got a box of old models, you know, you wrote model surgery, and this spoke right to my heart with model surgery.
Yeah.
Something I learned from being a GPR at Portsmouth Naval when they're doing orthodontic surgery, doing model surgery all the time. It's I don't I always have models printed and ready to go, and if I'm expecting zygos, even I'm not perfect, I don't do miracles, but we can all make mistakes, and we're all better with practice. So if I'm
For
expecting to do zygos, I go and look at the model, even if I'm gonna use dynamic guided navigation. I go and do the surgery, and I look at the sinus, and that's what you're talking about. I just wanted to show one of those. It it's not just for beginners. I think we can all the patients can benefit from a surgeon who runs the reps. The
you know,
quarterback
more
a quarterback at a Super Bowl doesn't go out and snap the ball without doing some practice throws before the game.
the more surgery I do in the zygomatics, the more I depend on the model. There's
Mhm.
absolutely no doubt about that. And also another thing I would say is that pilots do that. Pilots, when they decide to take a pilot and have him start a new route from New York to Australia, for instance, they don't just put him on a plane and say, "Hey, see you in
Yes.
Australia." They
Yeah.
put them on a stimulator and they stimulate the flight for that many hours. They literally want to build their fatigue endurance, and they put them and they stimulate the altitude, takeoff, landing. So it's the same thing. When you're doing an advanced surgery, such as pterygoids, bilateral zygomatics, and transnasals, that's a very difficult surgery. That's a very
Yeah.
highly sensitive precision surgery. So you need to stimulate that flight. And model surgery allows you to do that. In fact,
Yeah.
actually, Adam, when I first started,
When bone is limited, excuses don't cut it. Core Anchorage teaches remote anchorage, zygomatics, pterygoids, advanced fixation strategies for complex full arch cases. Expand your indications, treat more patients, increase predictability. May 15th through the 17th with live surgery and cadaver exercises. Register today.
I would do model surgery 2 days before. And then the day of the surgery at 5 a.m., I'll go do another model surgery
Yeah.
right before the surgery. When I
Yeah.
went to surgery, I realized that my hands were doing stuff that I wasn't even thinking. That
Right.
in fact, actually, my body was just on autopilot, and I didn't even have to look for bone, reflect, boom, get out. It's as if there was this muscle memory, as if this patient's anatomy was sort of in my mind and allowed me to
Yeah.
do quick surgery in and out. So I can't stress the use of models. So important.
Oh, absolutely. I mean, it's just the more repetition you get, the patient only wants to do it one time. You only want to do it for the patient one time. You only get one chance to do it on the patient that one time. It would behoove you to just kind of go through it for 7 minutes. Just go through it and drill some holes, and let's take a look at the anatomy. I
Yeah.
absolutely agree. I don't think we should rush these cases. And you want to get on that autopilot. The first time you drive somewhere, you have to look at a map or a GPS. You drive there 3 times, you almost do it with your eyes closed. You're listening to this podcast, and you're talking to the person in the seat next to you, and you don't even realize the turns you make,
Correct.
right?
Absolutely. You're spot on. Yeah. Couldn't agree with you more.
I can't wait to see you talk again, my friend. You're so calming, by the way. It's,
Oh, thank you. Thank you.
where do you get that from? You've got this aura of peace.
Yeah, thank you so much. Yeah, you always have to be at peace to be able to do good work for your patients. I
Yeah.
saw Pedro Mora one time post something on Instagram that really resonated with me. He said surgery is addictive, being a leader is addictive,
Right.
and sometimes that can get to your head. And you must always stop and remember that you're a human, and you must try to be humble and come back that you could make mistakes too, and be humble. So I always think about that, and try to bring myself down, because sometimes things can get to our head. It's important to remember that we're just humans, that we are the same, and we
Yeah.
are members of the same body, and we have to be kind to each other.
Yes. Absolutely, brother. We go to the same church.
Yeah, yeah.
Yeah,
Hopefully.
we go to the same church.
Yeah, yeah.
Oh, I wanna take advantage of your big brain while I've got you for a few more minutes. Are you good on time?
Oh, yeah, of course. Yeah, yeah.
O
A few more minutes.
okay. Because, being a very accomplished prosthodontist, I wanna talk about something that, I wanna talk about speech, I wanna talk about phonetics, I wanna talk about
Sure.
the dynamic, the positions of the tongue and the prosthetic. This
Agreed.
is where I think a lot of education is lacking, in dental prosthetics, the full arch world. I'm not just talking fixed, I mean dentures, overdentures, everything.
Sure.
What do you look for? What are your keys? What could you tell a young aspiring dentist? Okay, because everything is right now is just built on incisal edge position or built on, function occlusion. What's your occlusion? What's your occlusion? What's your occlusion? I think a lot of people get into trouble with phonetics and speech. What kind of advice could you give young docs?
Very long topic, but I'll try to narrow it down. Adam, an idol of mine is Peter Dawson. Peter Dawson published a book 20, 30 years ago regarding from functional occlusion to smile design. I read that book, and I remember in chapter 14 of his book, he talked about a concept known as neutral zone. And neutral zone is a zone that's basically dictated by the buccinator and by the tongue and the floor of the mouth and the palate. Violation of the neutral zone will result in problems. And violation of the neutral zone is why orthodontists have relapse, right? If you move the teeth outside of what the musculature can handle, you
Right,
will have a reaction to that push. And so
right,
to those younger dentists, I say, um, if you don't believe me, go ahead and pull up an MRI of I saw a guy do beatboxing inside of an MRI machine. And Adam, I was absolutely amazed by the floor of the mouth, the palate, the buccinator, the tongue, and what happens inside of the mouth. We have this unbelievably beautiful, intricate, precise, intricate, gorgeous system. The
hmm
soft palate, the nasopharynx, the back of the mouth, the epiglottis, the floor of the mouth, the palate, the cheeks, lip support, the three bands of the buccinator, the upper belly, the mid belly, the intermediate, the orofacial muscles. I mean, everything that comes together. If we do full arch and we don't pay attention to the neutral zone, we can really violate somebody's neutral zone, open the vertical too much. That
hmm
can really throw somebody off tantrum, and really they'd come to you and say, "Hey, um, I don't know what's wrong. I can't tell you, but I'm not comfortable." And
right,
so yes, I would say don't violate neutral zone. Respect the mouth. Only replace what was lost. Don't make too big prosthetics. Don't change the patient's buccal corridor. Don't
right,
push the teeth out too much. Don't open the vertical too much.
yeah,
Don't place your implants palatal. Don't create gigantic, large prosthetics. Pay
right,
attention to biologic width. Pay attention to speech. Pay attention to the tongue and comfort zone and the neutral
yeah.
zone, and you won't get into trouble.
You mean we just can't do bigger smiles, show more teeth, more
Yeah.
Hollywood, more Hollywood, more Hollywood?
Right,
Yeah,
right. Yeah, I think so. I mean, you will get yourself in trouble. I mean, I always look at a patient and try to stay where they are, right?
yeah,
I try to not to move stuff around. Of course, if we have someone that has a class 3 and their maxilla needs to come out. Yes, I get that.
yeah,
But 90% of our patients, they just have broken down teeth and terminal dentition, but their arch form is in this right place. Their maxillary mandibular relationship is in the same place. Their buccal corridor is okay. The midline is fine. All we need to do is lengthen the teeth and give them the right vertical, and we're done. So my
right.
suggestion is really pay attention to what the patient already has, and don't do too much, because when you do too much, then that's when you'll start having problems because you violate their neutral zone.
Yeah. I just grabbed a quick picture of yours and to illustrate some of the points you made. Just making sure that everything's in the prosthetic space. And we encounter this every day, and I think that's where a lot of people get into trouble. They just think they're going to drop in implants and then they're just going to take some impression scans and it's all going to work out. I
Correct.
mean, I had a patient come here from somewhere else. The all-in-4 was failing, constant screws popping, breaking. Then they had bone loss. Then they're going into remote anchors with me. And I looked at this woman and I said, "What do you think about your smile?" She said, "I love it. I love everything they did about my smile. It's big and beautiful." And I took a scan of her in maximum intercuspation, just in her CO, and her condyles were both translated severely open. And
Oh,
I
wow.
I said, "Okay, blah blah blah. I've got some new. I need to change your smile. I don't change my smile. I want exactly the same." It's gonna be. I gotta. So I had to close her like two and a half, you know, to get her condyles seated. Um, and it can happen on my patients. I mean, I remember the last year I had a patient that was finished and she came back and she was super happy with her big, beautiful smile. And it looked pretty good, on all respects, but she was quiet going through the pros phase. And she came back, she said, I'm just not comfortable. Just not comfortable, you know?
Agreed. Yeah,
And
I see it.
yeah, I said, let me change. Let me go back. Let me work back. Closed her vertical, maybe one and a half, two. As soon as I put the new teeth in, I walked away 5 minutes later. Oh my God, that feels so much better.
You
You
see?
know?
You see? Yeah,
Yeah.
because you took her back. You stopped violating her neutral
Yeah.
zone, and you
Yeah.
brought her back into what you mentioned. I like that word prosthetic space. You're right. You brought her
Yeah.
back in. And
Yeah.
while we're on this topic, I also would say, Adam, in that that is the reason why we should depend on ourselves as doctors,
Yes.
taking our own photos,
Yes.
doing our own diagnostic workup, designing our own cases with the technician's help, of course.
Yeah.
Because I see a lot of doctors, they just accept the case, they go to surgery, and then they punt everything over to the technicians. The
Yeah. No.
technicians are not going to troubleshoot. Technicians don't know about buccal corridor. They don't
No.
understand the floor of the mouth. They don't understand vertical dimension. They don't understand free space. They don't
Yeah.
understand inside the ledge position. They don't understand phonetics. They don't
Right.
understand floor of the mouth. So how are they going to bail you out? You need to
Yeah.
know this stuff yourself, learn them, even
Yeah.
if it's in an analog way, and then you can delegate that responsibility to someone
Yeah.
else.
But you do have to be the doctor. And, I think I'm pretty good, but there are times you just like, you do a lot of volume or something, something doesn't go right. You got to revisit it. You got to fix it. You got to admit it. You got to go back. And you also have to listen to the patient. I think this is the biggest take home that I give with pros. People, you know, what's the key to pros? I think the key to pros is listening to the patient and
Yeah,
watching the patient. I've walked into so many rooms where the technician says, "Doc, final scan for zirconia. Patient has no complaints. Can I just scan him and let him go?" No, I want to come in. And you go in and you go, "Hey, what's wrong? Everything's fine. I love it. Everything's great. No, it's perfect." I'm like, I see tension. You just see it in their brow a little bit,
exactly. Agreed.
and you have to say, "Whoa, step back. Let me do something to your bottom teeth." Or
Yeah,
whatever. You take it out their teeth, you grind off a millimeter or two, or you reprint and try it in, and they go, "Oh my god, I didn't know." But you
agreed.
gotta watch, you gotta be the doctor, you gotta walk in and look.
Exactly. If you're giving that responsibility to a lab technician, you don't see this stuff. If you're not looking at their pre-op photos, if you're not recording their vertical dimensions, now, Adam, I mean, after 16 years, just about last year, outside of lateral photos, intraoral smile, and a smile photo, now I'm doing videos too. Because
Yes.
if you do a quick video and just upload that into Google Drive, if you
Yeah,
ever need to go back and see how they move their mouth, what
yeah,
was the relationship of their 8 and 9 with the lower centrals during phonetics, that can
yeah,
give you so many clues and can really bail you out and get you out of trouble. So the more information you have, the better. And
yeah.
technicians are not trained to do stuff like that.
No, no.
Yeah, we have to be doctors first.
I've got, my phone here, and it's always in my pocket because 'cause I'm always, like, writing a note or I'm, telling the lab something or put this in that lab script, some notes or a voice memo, and oftentimes, I'm like when I walk into a room, I get the patient just to talk, right? And I wanna hear about their day, but and their life, but I'm also watching their teeth the whole time and listening the whole time. So I don't have to go, "Okay, let's get to your teeth. Count to 10." You know? Like, you know, and if they're talking and I see a problem, I might pull out my phone and I'll be like, "Hey, ignore me. I'm just recording something for the lab. Yeah, keep on telling me about your vacation in Hawaii." And I'm going around, going
Correct.
around, going
Correct.
around. And then I'm like, when I go to my office, I send a slab, I say, "Watch the patient's lips catch on the number 11," whatever, so they see that, they
Abs-
know. Listen to the patient, listen to their tongue doesn't have enough space. Listen to that, hear it.
Absolutely. Adam, I mean, sometimes you could really go far with this. Look at the tooth mold. If they have triangular teeth, give them triangular teeth. If they have
Yeah,
square teeth, give them square teeth.
right,
Nowadays with full arch, everybody gets the same mold.
right.
That's not how we should be doing cases. We should, I remember a girl, I gave her triangular teeth, and she said to me, she's like, can I give you feedback about something? I said, what's up? She says, my dad saw me at a Thanksgiving dinner, and she said to me, hey, baby, your teeth looks just like how you were when you were younger, right? And that's the
Yeah,
biggest compliment you can get from your father, right? So
right,
really customizing this, we hear these DSO type clinics right now, they're delivering the zirconia in 24 hours. Give me a
yeah,
break. I mean, that is just, you cannot, I don't care how good you are. Biology is an uncontrollable force. You got to let these patients heal, and then you customize another permanent restorations onto their existing ridges,
right.
and you just can't get all that information from the start for 24 hours. I get so angry when I see that. You
Oh,
got to let patients heal. You got to let them reestablish their maxillary-mandibular relationship, their speech, their phonetics, their aesthetics, their comfort zone, cheek biting, lip biting, aesthetics. They need to hear compliments from their family members. They need to wear that
yeah.
stuff so they can, yeah. Unfortunately, sometimes we see marketing become the sort of the decision maker here, but you got to let patients heal. You got to give
And
them teeth so they can function in it.
I couldn't agree more. And they, this the doctor that's going to get in trouble, not the corporation, unfortunately, until
Absolutely.
some class action lawsuit, some big wig lawyer realizes, what the company was doing to these doctors.
Correct.
But on the ground level, it's the doctor that's going to get in trouble, not the corporation.
Correct.
I mean,
Correct.
am I the only one, Safa, you're a board certified prosthodontist. Am I the only one who delivers beautiful teeth the day of surgery or even, maybe, the next day after like one refinement? You're like, okay, you see something, you switch it, you balance it. So I bring them in the next day. Perfect. Okay, it's perfect. On within 2 hours or 24 hours, it's perfect. And they come back for like a 6 week wellness check and the bite's open a little bit on one side or the midline is just off a little bit.
Oh, absolutely.
I mean, this stomatic system, I mean, I call what they come in with as their best fit match, right? To borrow an exocad term.
Correct.
And they've
Correct.
got learned behaviors, and it takes 6 weeks to deprogram. And where have we heard that before? Deprogramming. I mean, we've
Correct.
been hearing it in dentistry for 40 years,
Correct.
at
Absolutely.
least. And you just to say that we deliver perfect teeth the next day, even half the time, I think is ridiculous.
It really is.
Absolutely ridiculous.
Yeah.
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 I mean,
It's amazing.
so a
You
prosthodontist has those problems too?
Oh yeah, I mean, you know, I'll just add one more thing to this, Adam. I take pride in fabricating a customized prosthesis to the
Yes.
patient after healing. I take pride in that. I mean, I enjoy that, right?
Right.
To see this ridge, to look at the tissues around the multi-units and see how everything kind of remodeled, and then slapping another scan or impression off of that, and then fabricating another prosthesis on top of that. That's what I would want for my own mom, for myself. And
Right.
so, yes, absolutely, customizing and you go to a wedding and you get a custom suit. You get a baby, you start eating, you get a little bigger. You want to go to another wedding, you have to go customize a new suit, right? So, I mean, if patients get these teeth and prosthetics, to go to the final, you need another mold. You need to recustomize that prosthesis to their new remodeled that gingiva and tissues.
You talk about gaining weight through babies and needing another suit. I see you followed me through my, weight gaining years, and,
I'm going through it myself. That's right.
I'm proud to say I'm in my weight shedding year this year. I'm
Good,
doing I'm
good,
doing
good,
better. I'm trying to get below 200 again. Ugh,
good.
the
But I,
life
but I, way too many expensive suits in my closet, so I need to control the weight gain and weight loss.
I feel exactly the same way. I'm like, "Oh my god, that jacket, I need to fit back into it. I paid too much for
Yeah.
it."
But yeah, so I take pride, and really, I do take pride, and we should all take pride in making a prosthesis after the patient has completed healing, and that's the most beautiful part of full arch is seeing how your patient's gums and attached gingiva and soft tissues are responding around your implants, and then customizing a new precise prosthesis to that new remodeled ridge. When you do
Yeah,
it right after surgery, how do you know how much biologic width distance do you have? How do you know how much that patient is going to resorb? How do you know what's going to be the sort of
yeah,
the behavior of the soft tissue around the multi units and the establishment of the biologic width? You don't know that. It's all guesswork. And if
right.
somebody's paying you $50,000 or $40,000, you shouldn't be doing any guesswork for them. You should really do a customized prosthesis that's going to be with them forever.
Yeah, I 100% agree with you. I know you this has been I feel like we could talk about lessons in prosthetics and, I prosthetics is near and dear to my heart because, um, I mean, I just love the result that it gives to patients. You know, the implants are a bonus. You know, the implants are they're fun, surgery's fun, high production, all that stuff. But, you know, the prosthetics, I think where the enjoyment's at with meeting people and changing their lives. I could you be just a doctor who goes in and just places implants with patients asleep from operatory to operatory to operatory to operatory? I can't either.
No,
No,
no.
I
I mean,
can't.
when you do the surgery with the prosthetics, I always call it beginning with the end in mind.
Right.
And when you build a house, first you have a blueprint, and then from the blueprint you build a house. It's the same thing. You got to
Yeah.
have that prosthetic nailed down before you could do surgery. Agreed,
Yeah.
100%.
Yeah, it's one thing to build a house and go from the bedrock to the supports to the foundation and up, and it's another to walk in on the lot and look at the sunset and the sunrise and the trees and go, "Where do I want my porch and my roof?" You know?
Mhm.
And now, okay, let's go down from the sun down. And I think that's the crown down technique, I believe, if you were using a house reference, right?
Ag- Agreed.
Yeah.
Agreed.
I couldn't be more you know, so you agree with my idiom of, patients live in surgery, but practices live or die in prosthetics?
Right, agreed. Absolutely.
Yeah,
Absolutely. I mean,
yeah,
there are three things that will dictate longevity for our patients. Number one, soft tissues. We need to have good soft tissues. We can't ignore that. It's a peri-implant soft tissue seal is paramount. Number two, bone stability. We don't shouldn't only preserve bone around single implants. We should preserve bone around our full arches too. And number three, precision in prosthetics. If
mhm.
you can have those three, you can have success. And it's not hard to do. You just have to pay attention to detail.
I agree completely. Alright, so what are we gonna title this? I
I don't know. Friday morning chit chat. I'm not sure. Whatever you think, I'm
don't
with
know,
you.
avoiding a $50,000 mistake,
Yeah.
some
I wish it was that easy and we could do it over a podcast. But yes, it's a lifelong educational thing, and we learn from each other, and we learn from our mistakes, and we should be learning from our patients and our cases.
Yeah,
100%.
yeah. Well, is that I guess those are some good parting words. Do you have anything else you wanna say? We're running a little over an hour. I know you got a baby coming home. I got a baby
No,
at home. What you
no. Thank you for this opportunity. I've been watching you. You're definitely an influencer. You have a lot of following. People listen to what you have to say, and for you to include me is definitely an honor. So I really appreciate you putting this together, and I enjoy these podcasts because it allows us to talk about stuff that doesn't really get talked about that often. So thank you for putting this together.
Well, it's in my honor that you're here. I mean, I've been watching you, watching your work. I've seen you on stage. Gorgeous, gorgeous photography with is just displaying some beautiful prosthetics and surgery. I know you've got a stage, you at the Picos Institute. I know you've got a stage at other symposiums and whatnot, but the world could benefit from hearing more of you.
This episode of the All In, All In X Pod is powered by JB Dental Lab, your full arch lab partner for predictable, beautiful, and digitally precise results. From provisional same-day conversions to final zirconia, JB delivers consistency, communication, and craftsmanship that elevate your practice. If you're looking to grow your skills, JB's Educational Center hosts hands-on courses with live surgeries. Ready to streamline your All In X workflow with a lab that truly understands the surgical and prosthetic connection? Visit jbdentallab.com and tell them the All In, All In X Pod sent you. Thanks for listening.
Thank you.
With your calm, cool, humble approach to doing complex surgical and prosthetic work. I mean, you're the kind of educator and example of a man that I really want to see on stages more often. So that's why I asked you to be on here for sure. Yeah, thank
Thank
you.
you, Adam. And I would add to that, it doesn't happen overnight. We are all the reflections of our mentors. So
Mhm.
I come from a very strong educational background from SUNY at Buffalo, upstate New York, from having these phenomenal dental school teachers, which most of them have passed away, unfortunately, at this point. Then to my most recent mentors, such as Carlos Aparicio, Dr. Kosta Nikolopoulos, Mike Picos. These guys are our mentors, and they've really have paved the way for us. If they didn't make all those mistakes in Zygomatics, we wouldn't know how to do the right Zygomatics today, right? So,
Right.
kudos to those mentors who have really paved the way for all of us, and allowed us to do what we do today. So we must never forget that we ourselves have learned from masters prior to us, and we should be humble, and we should pay tribute and respect to those guys, because they didn't have the implants we have today. They didn't have the CT
Yeah.
scans we have today. They don't
Yeah.
have the pictures we have available to us today. They didn't have the knowledge we have today. They
Yeah.
don't have scanning, facial scanning, the photogrammetry. They didn't have any of this stuff, but yet they did it. And we
Yeah.
learned a lot from them. So kudos to them.
Amen. Yeah, and we owed it to give it back. I can say the same thing for my mentors. God, thank God every day for my path and for meeting these people and going down that route. And now, it's education doesn't pay much, it's
No,
just something that I feel like we have to do. I want to do to give back and help the next generation to succeed. I'm sure you probably
right.
feel the same way. There's
Agreed.
probably less than 3 people making a living on education, if I had to count.
Yeah, nothing makes me more happy than to have a patient come and say to me, "Hey, thank you, you changed my life." That's the first thing. And the second thing that makes me even happier is when I have a student or someone that I've mentored along the way and come and say, "Hey, what you taught me there really helped me." So because I remember feeling the same, having someone I learned something from someone helped me to be able to get out of a sticky situation. So yeah, definitely I agree with you. We must remember where we came from.
Yeah, absolutely. Speaking of where I came from home. You're at home. I'm gonna go
Yeah,
back home, Safa. I want to thank you for spending this time with me, and we'll chat a couple minutes off air. But for everyone else, you want to get in the full arch dental implant world, you better get your head straight, and you better go all in if you're going to go in at all,
and
right?
have a right mentor, have mentorship.
Yeah,
Don't do it on your own. There are people out there like Adam that are willing to teach you at
yeah,
the institute that you have there. Make sure you find somewhere and stick to a protocol. Albert Einstein says it beautifully: do something, get results, and then decide if you should do it again. And so do the same thing over and over. Don't change around too much, because you need to see your results. And if your results give you feedback, then from that feedback, you decide whether you want to continue doing it or you should change the way you do things.
I agree completely. What I'm going to finish on those words of wisdom with Safa and Albert Einstein. Thanks for
Yeah.
spending the morning with me. All
Well,
right.
that's it. Thank you so much.
Peace and have a great weekend, Safa.
Yeah, Adam. Thanks for the opportunity.
Hey, if today's conversation resonated with you and you're looking to sharpen not just your technique, but your judgment, your discipline, and your long-term vision, then this is exactly why we built the Atlantic Implant Institute. This is not just some weekend course or module. This is not just some highlight reel. This is not just some collection of disconnected modules. This is the core continuum for education and full arch workflow. It begins with Module 1, Core Bootcamp Fundamentals, where we establish surgical foundations, diagnostic discipline, and repeatable decision-making under real-world pressure. And then it continues with Module 2, Advanced Prosthetics and Full Digital Workflow, where occlusion, vertical dimension, aesthetics, condyles, and execution all converge. And then we have Module 3, which tackles remote anchorage, pterygoids, zygomatics, complex anatomy, taught through biomechanics, planning for predictable outcomes. And after the continuum, we have modules in FP1, fixed immediate load, and also business, how to 5, 10, 20. This is business, leadership, and operational strategy so that you can build surgically what actually works in practical business. If you're ready to go into full arch dentistry with intention, structure, accountability, and purpose, you can learn more at theatlanticImplantInstitute.com.